Hello, good evening to all of you. I'm Vasundhara Raghavan, calling from India. I represent Kidney Warriors Foundation, an NGO for supporting kidney patients in India. Today I'm going to talk about caregivers' concern over kidney graft rejection. At first, we need to understand the dynamics of a kidney and the graft. Because as soon as a transplant happens, there is this freedom from dialysis and it establishes comfort in the recipient. At first, the transplant is only an incident. Over time, as the organ settles down, it is taken for granted, a certain ownership develops. And then, an incident called rejection rocks the peaceful boat and brings life to a grinding halt. There's an historic perspective to graft failure. There's a study based out of US and Canada conducted in 2004 where 17,000 transplant recipients were under the research. About 30% kidney recipient experience graft failure in the first 5 years. In most cases, late rejection occurs following chronic nephropathy, and in a smaller percentage people people due to late acute rejection induced by poor compliance with drug therapy and follow-up regime. We have some insightful data from the US which shows that even in advanced countries where transplant practices are very far ahead than in the developing countries, between 1998 and 2010, dialysis suddenly rose by 50% due to people coming back into the regime after graft failure. In 2013, 14% began dialysis due to graft failure. 11.5 returned to dialysis the same year of the transplant, which is a very disturbing thought. Commonly known fact is graft loss increases risk of mortality 3 times more than in a normal person. Survival of 5 years post graft rejection is less than 40%. To bring out such information critical for developing strategies for improved graft survival, a center in Brazil undertook a new study. The graft failure study that Brazil brought out is a cohort study with 944 patients who underwent a transplant between 2002 and 2015. Study conducted to assess causes of death and graft failure included all persons with kidney transplant parameters gathered with age, sex, ethnicity, and donor type, deceased or live donor. It excluded multi-organ transplants. Graft loss information collected was as below. Primary non-function immediately post-transplant without start of function. Early death post-transplant without start of kidney function. Death with functioning graft and graft failure. The highlights of the study showed male 57.4% were recipients, of white ethnicity 68.8%, with an average age 43.5 years. 54.2 received diseased donor transplant. The age data showed 2.2% below 18 years, 38.9% in 18 to 40 years bracket, 53.4% in 40 to 65 years bracket. In 68.1 months follow-up time, 217 grafts were lost. 23 patients due to primary non-function, 10 patients due to surgical clinical complications without renal function, 42.4% with functioning kidney now presented for failure, 42% again, death with functioning kidney. The aftermath of a graft failure, most of the shocked patients start dialysis immediately. However, two-thirds of patients seek another transplant. They see better quality of life, and that becomes the predominant factor for this choice. The second transplant always comes with psychological evaluations to determine the patient's state of mind. The challenges faced by patient is denial and acceptance. The patient is confused about the new mystery. The shock is similar to the one at the start of the journey. The earlier "not me" still haunts. Starts dialysis with the hope that anti-rejection medications will jumpstart the kidney. Months of dialysis, slowly it dawns that reversal is not possible. Some retrospection is ongoing on what went wrong. Losing a graft is akin to losing a dear one, overwhelming sorrow, desire to get liberated. Suicide crosses the mind so often till the depression subsides, if it will. Another circumstance and challenge: life under dialysis is more depressing now than before the transplant. Diet changes, restrictions come back, free time is reduced, ability to manage job or education gets hampered. For many people, partners leave them, and depression reigns. The greatest truth is the water challenge. Dialysis prior to transplant meant 1.5 liters fluids, water, and all liquids. Then the transplant gives you liberty to drink more water, 3 liters or more. And then when the graft failure happens, restriction is clamped back to 1.5 liters water or other liquids. Water restriction is individually applicable as advised by physician. In all this, the caregiver is a silent spectator. Impact of graft loss penetrates into the family. Everyone is grieving silently, heartbroken, and trying to restore normalcy. Role gets intense, more hours to clock in, practicing the art of listening, knowing, and sensing, offering support at all times, selfless effort to keep patient on track, breaking down all negativities with positivity. The caregiver, if mother, continues to mourn, seeing the person on dialysis. This state exists till the next transplant, with deep regret, wondering on what went wrong. But one needs to question, how deep is the well of love? How much more can the mother give or the parent give? From self-initiated studies from our group from the Indian subcontinent, we have this age group classification where we found out 71% in 15 to 30 years belong have a CKD, and it leaves me wondering that in case this age group 15 years to 30 years face graft rejection, what would their what would it how would it impact their lives? Because this is a very beautiful age group where people have so much fun. There's so much to achieve, and all the work gets done around this time. There are age related aspirations. There is something like a marital status that people are looking forward to. as they cross 20, 21, 22, and then if they are with CKD, some stage of dialysis or transplant or whatever CKD it is, they face a situation where marriage can become a problem. In our case, 46% were unmarried in the age group 20 to 40 years. So that is a social problem where all people in this community can look at it closely to understand, to introspect and find out how to create opportunities. All this time, the caregiver stands alone, guilty. There's a pressure of challenging, of preparing patients for the setback, the constant reassurance needed to face graft loss. Younger patients see less hope about their future. They look at the jobs, education, and matrimony as things that are not in their plate. This is a high dependence group, handling new emerging health complications with coming back to the dialysis. New health complications emerge, and this needs to be resolved or to be handled. So the caregiver steps into the shoe to find out how to handle these health complications. There is always a worry about the patient's education and disappointed over the society attitude. How does a caregiver manage in India? Kidney rejection is real. Caregivers who work hard to see their loved one is stable with a transplant find rejection very discouraging. It is established through studies that there's an emotional and mental burnout. Spouses are pillars of strength, emotions remain suppressed, physical desires are sacrificed due to moral obligations. Primary concern is family, ignoring their own well being. Fathers agitate, unable to talk about their sleepless nights, seeing child's setback. Siblings handle it differently. They mentor, motivate the affected person, but deep inside, their hurt stays buried. Caregivers' concerns are many. In India, it's also the transplant costs, which are huge. Dialysis is a continuous financial drain. Many patients need to self pay for CKD treatments. Getting another organ, altruistic donors are not easily accepted. Cadaver transplant is a long wait. Sometimes health changes during this wait period. Patients and families are exposed to uncomfortable questions from friends and other family members. Burden of a graft loss cannot be accurately summarized. Caregivers stand alone clueless. In India, financial planning is an issue because insurance for pre existing conditions is not prevalent. Self financing is a huge drain. Family sacrifices indeterminate. Uh, Below the poverty line for government funding is for people with income less than 10,000 rupees per month, which is dollars 140 approximately. This does not consider family size and overall living costs. Financial pressures, monthly dialysis expense for thrice a week, approximately dollars 133 at the lower end and dollars 745 at the higher end. And annual can go up to dollars 8,950 at the upper end. People on dialysis largely depend on family to support medical expense due to physical inability to do regular work. Sense of being a burden is a huge aspect to be handled in India and elsewhere. All over the world, caregiver is alone in loss of life. End of a patient's life, Caregiver and family have no shoulders to unburden their big loss. From the start of the journey, patient and family were left isolated because of the sympathy and judgments that cut off strong relationships. In death, they grieve alone. A gentle hand of love is needed to help people forget the gruesome details of the dark faces. The need for now is better facilities for patients and caregivers, good support groups to make them feel worthy, job opportunities for all kinds of skill sets, insurance schemes in developing countries. People must be made aware about the extent of the caregiver's work, encouraging them to extend emotional support. Caregivers, as spouses, need more love from community to replenish loss in caring. Caregivers' role can never be underestimated. One has to understand, realize, and accept that caregivers are integral part of the kidney journey. Due respects and regards. Thank you. If anyone wants to reach out, my contact details are here. I hope you enjoyed this session. Thank you.